السلام عليكم. أعتقد الأغلبية تعبان يعني. I know it's a long day. That's why I choose to be the last. So at least if you are sleepy, then maybe you'll wake up with me. I'll try my best to make you. Where did you put it? Yeah. Immediately to the pain management. That's the start, you know. They want to push me quick. So every one of us, we are saying we are a pediatric gastroenterologist, we are a pediatric hepatologist, maybe we are saying pediatric nutritionist, pediatric endoscopist, but we never say something related to the pancreas. So we don't know if this pancreas is belong of the pediatric GI or belong to the endocrine or where it's going. And I think this is one of the problems in pancreatic disorders in pediatric. Really, there is no much data, even in Europe, in North America. The most data comes from adult studies and literatures, and the guidelines all come from there. So we'll come through that and we'll see. So we'll talk first reintroduction just to some mechanism about the acute pancreatitis, diagnosis, management, and the outcome. So the pancreas, we know, it is divided between us and the endocrine. So our part, which is the exocrine, which comes all through the acinar cells and giving the enzymes we need for the digestions, while the islet pancreatic or islet cells is giving the endocrine functions. So this is our target here. So we know that the acinar cells here is having a special characteristic which have zymogen granules, and this zymogen granules is the place to store all the enzymes actually in active form. So most of these enzymes in active form. And once we need it, once the diet is there, it will be excreted and will be activated later on in the duodenum. In the duodenum, when the duodenum receives the food or nutrient in the acidic media, you will need a lot of buffering, which is usually secreted through the centroacinar cells. And this will lead to a lot of fluid going down to the duodenum, taking with it the enzymes we need for digestion. So that's what the main enzymes, I'm saying the father of this enzyme is the trypsinogen. You know, if the father is wake up in the morning, everybody will wake up. That's simple. So he will wake up everybody. So once the trypsinogen activated, and these the enzymes, the usual enzymes activate trypsinogen, mainly the enterokinase and also the others. Once it's activated to trypsin, the trypsin will activate the other enzymes to the chemotrypsinogen or phospholipid lipase, all will be activated to the active form. So this is the normal, okay? Most of this usually happens in the duodenum. Sometimes this can happen inside the acinar cells, okay? And the acinar cells having ability to tolerate a little amount of trypsins because of the pancreatic secretory trypsin inhibitors will bind this trypsin and will deactivate. So there will be no problems with the little amount of trypsin inside the cells. Also, there is another mechanism through the chemotrypsin C, which will actually break down the trypsins, and that also will decrease the level of trypsin inside the acinar cells and also break down the trypsinogen. So you'll not have enough of trypsin to actually injure the acinar cells. If this enzyme trypsin reach to the blood, again in the blood you will find two actually enzymes or hormones, the alpha-1 antitrypsin and the alpha-2 macroglobulin will bind the trypsin, and there will be no harmful from being in the blood as well. So that's the usual, the normal. So what happens before we go back to that slide? We will go through the pathophysiology in acute pancreatitis. One of the most common is the biliary pancreatitis, which is maybe duct obstruction. This is the commonest cause in adult, plus the alcohol. So duct obstruction like cholelithiasis or congenital anomalies usually will lead to interstitial edema, which will lead to impaired the blood flow, and that will lead to ischemia. And the ischemia will injure the acinar cells. The others, like virus, trauma, or even alcohol, also having direct injury to the acinar cells. All of these will lead to intracellular activation of trypsinogen, which will lead to activating of the other enzymes, as we mentioned before. And the acinar cells injury that will happen. This mechanism, because of the enzymes, you see these different enzymes causing different mechanism leading to the injury of the acinar cells. Acinar cells injury response will lead to more of interstitial inflammation, and that will lead to acute pancreatitis. So that's the cause of acute pancreatitis. If we go back to our diagram before, which is related to the usual physiology, if this is activated in the acinar cells and you have BRIS mutation, which is the most common actually, will lead to increase the trypsinogen activated to trypsin inside the acinar cells. That's why the BRIS1 mutation, they have high risk of recurrent acute pancreatitis. The other, which is the SPINK1, actually it's affecting the pancreatic secretory inhibitor. So you will not have enough defense there against whatever activated inside the acinar cells and will lead to recurrent pancreatitis. Also the third one, which is chymotrypsin C mutation, will lead, or actually will affect this one, chymotrypsin C, and will affect this pathway, leading to recurrent acute pancreatitis. The CFTR variant, which usually if it is there, the secretion and the fluid going down to the duodenum will be very slow, and that will lead to block or the ducts and will lead to recurrent pancreatitis. So this is just brief regarding the hereditary causes of pancreatitis. We're going back to the acute pancreatitis. So we know there is tissue digested by the pancreatic enzymes. You will have a lot of inflammatory cells initially, a lot of inflammatory cytokines. On the other hand, to balance the things, you will have the anti-inflammatory cytokines, and both actually will harm the pancreas more and more. All of this will go over the pancreas, and we have to balance this as much as we can. So the inflammatory cells will lead to the systemic inflammatory response syndromes, okay, which will lead to activation of the vascular endothelium and neutrophils, and will help for biological defense, but will lead usually this to the early phase complication, which is multi-organ failure. While the other one, which will develop later, the compensatory anti-inflammatory response syndromes, will have excessive of anti-inflammatory response. This actually will affect the immunity system, and you will have a lot of infection, and this is what we see in the late phase complication, which is like infected pancreatic necrosis, pancreatic abscess, or sepsis. So that is the mechanisms. Going back to the acute pancreatitis. So the acute pancreatitis, as I said, most of the studies comes from the adult. But once we got these groups, which is the INSPIRE, they call them is the INSPIRE group, they start to work hardly to develop scoring, to develop guidelines, and the recent guidelines from the North America, it's actually through these groups, which was published just January 2018, and most of our review here will be through that review. The incidence is 1 in 10,000 and children per year, and they thought it is actually going up. Usually it is mild form. Etiology, most of the time, there is different etiologies. We are not like the adult. The most common is biliary and alcohol. No, in pediatric, well, there is no much difference. Most of them, they are saying idiopathic, trauma, systemic illness, but you see that difference, 17, 15%, 14% in this study. And in the other studies, almost the same. So they are almost the same. The only things always we actually think that's the infections behind it. Infection is one of the, it's actually not one of the common etiology. And this is another study showing the same. Regarding infection, mumps, we know that's always comes to our mind, but don't forget mycoplasma. Mycoplasma, one of the other causes. And even if you have mumps, not necessary to involve the salivary gland to have pancreatitis as well. Regarding medication, the commonest medication is valproic acid in the children. The second one between 0 and 10 is actually steroid, okay? That is if you compare how frequent we are using steroids. That's why it is more seen to cause pancreatitis. But there is other medication can lead to. How to diagnose? So this is the criteria developed by the INSPIRE. You need two of the following. You need abdominal pain compatible with acute pancreatitis. You need serum amylase and or lipase, one of them or both of them, but they should be more than 3-fold of the normal limit. If one of them is missed, so you need image to support your diagnosis. The clinical presentation, we always learn in the medical school that is epigastric radiated to the back. Actually, most of the times, yes, abdominal pain is the commonest. Most of the times is epigastric, but up to 20% they can come with diffuse abdominal pain. And you know, children, sometimes it's difficult for them to give you the right answer. Regarding radiation to the back, is just seen in the 5%, so it's not necessary. Epigastric tenderness, nausea, and vomiting, one of the or other common presentation. And don't forget the specific signs like Cohen signs and Great Turner signs. However, they are not seen frequently. What about the enzymes, lipase and amylase? We learned that lipase is more sensitive because primarily excreted from the pancreas, while the amylase primarily excreted from the salivary gland and pancreas. So it's not primarily only from the pancreas. The second things, actually the lipases take time till normalize. So if the patient present later on, still you can pick up that patient. While the amylase will be normalized within 24 hours, so you can miss it if you don't have the lipase. So lipase is more sensitive, more specific. Yes, there is another causes, all these causes for high amylase and lipase, like renal failure, liver failure, intestinal inflammation, DKA, abdominal trauma, head trauma, and the entity of macroamylase or macrolipase, which is actually a benign entity. It's only their actually enzymes is big and cannot be excreted through the urine, so accumulated in the serum without any inflammation. What's the image? Yes, they do chest X-ray and abdominal X-ray just or make sure there is no complication or other problems, but the usual, we need the ultrasound. The ultrasound is easy and very helpful for biliary pancreatitis. The problem with ultrasound is the gases. We know that the pancreas is retroperitoneal, so if there is a lot of gases, maybe it will be difficult to visualize the pancreas. However, it is the only one you need maybe at the beginning. CT scan, if you need to do CT scan, do it, but if you don't and the patient is stable, no need to do it. And if you want to do it, it's better to delay it after 96 hours. Otherwise, if you do it early, you will just see a lot of edema, nothing. You want to assist the complication, the necrosis, so it's better to delay the CT scan if you want. It's very helpful if you will do the CT scan to see the severity of index, but it's not routinely usually or recommended because of the age group and radiation. MRI, if there is problem doing CT, then you have to go for MRI, like young patient or pregnant. MRCP only recommended after the attack of acute pancreatitis, not during. Yes, sometimes we want to know what is the cause, but it's not recommended to do it during the attack. What other investigation important? Yes, CBC, liver, because biliary, it's one of the common causes, so you need liver enzyme and bilirubin. You have to check the triglycerides. We know that hypertriglyceridemia, one of the causes. Hypercalcemia, one of the causes, so you need to know what's the level of the calcium. That is on admission. And the serum electrolyte as well. Scoring system, all scoring system in adults is failed to be applicable in children. So nothing, not sensitive, not specific at the end. The only one is the CT. The CT, it's a good one. It is reaching around 90%. The pediatric trial always failed, maybe because of the difference of age, so we don't have till now accurate scoring system. However, the latest one by the ZABU was depend on the albumin, lipase, white blood cells within 24 hours. Maybe this is the best we got till now. Maybe we have later on. So this is the CT usually scoring. You can find it everywhere. That's how to score it. And depend on the severity index, you will know the mortality and the complication. There is another diagnosis of another, actually, Abul Hajj. He's one of the expert people. He put this diagram just to simplify the scoring, but is not accurate. So diagnosis based on the INSPIRE criteria. And look if there is organ dysfunction. If there is organ dysfunction, see if it is transit, it's mean less than 24 hours. If no, then this is severe, if it is more than 48 hours. If it is yes, just transit, then this is moderate. And the other, if there is no organ transplant, you will look to the local complication or to the other systemic complication or exacerbation of prior comorbid disease. If yes, then this is moderate severe. If no, then this is mild acute pancreatitis. This is how to classify it. Management, we have to go be more frequent. So a lot of things, the hypothalemia, the increased capillary permeability, the formation of microthrombi, this is the most important factors leading to alteration in the microcirculation of pancreas. And this is usually lead to progression of acute pancreatitis. So we have to stop this. The only way is a good hydration or good IV fluid. So the IV fluid is not here, is not just supportive. It is helpful for stopping all of these factors or at least reduce them. What about the recommended fluids? We know that's normal saline. However, in the crystalloid. However, in the adult, they found the ringer lactate maybe it's higher than normal saline, with decreasing the multi-organ failure and leading to the acute severe pancreatitis. But in pediatric, it's normal saline with D5. That's what you need. Colloid is not recommended unless the hematocrit is less than 25% or the albumin less than 2. This is the only indication for colloids. What about the fluid management? The aggressive fluid management is debated. As you see here, we have to weigh the two things. If you give a lot of fluid, you will end with accumulation of fluids, pulmonary edema, pleural effusion, a lot of ascites. If you give less fluids, you will have more of systemic inhibitory response syndromes effect. So what to do? If there is hemodynamically compromised, you have to give the bolus of normal saline, of course. After that, children recommended just 1.5 to 2 or double maintenance. That's what's recommended, especially during the first 48 to 72 hours. Not more, not less. But with that, you have to monitor the urine output. This is your marker to increase it or decrease it. So you have to keep the urine output between 0.5 to 1 cc per kg per hour. Here is, if you see that the IV fluids, here this is study showing, okay. So this is study showing two arms here. The first and the second arm. Let us concentrate here while the patient MBO. If you give IV fluids, all of the length of stay, severe acute pancreatitis, and ICU admission, and readmission, all will be decreased much. So IV fluid is not just supportive here. So monitoring, because of all of this, increased endothelial barrier permeability and profound cytokinin release and aggressive hydration over these, this is actually increased the patient risk for the third spacing and developing the extra pancreatic manifestation of acute pancreatitis. So we have to monitor mainly cardiovascular, hypothalemia on admission, one of the poor prognosis in adults actually. And even tachycardia considered in the scoring in the adults is one of the not good sign actually, and you have to take care. Cardiac tamponade and atrial fibrillation were reported in adults. The other system is pulmonary. They can have ARDS, they can have pneumonia, pleural effusion, especially during the first 48 hours. I told you from the beginning. Khalas, we conclude. Huh? والله كويس بريك والله ما ادري ايش هذا. ما يكونوا حاطينه بالوقت هم. انا اقول لك شكله كذا يعني. الناس طفشانه. 5 إلى 5. المشكلة حتى هذا قفل. حتى هذا قفل. طيب حل. في عمل ولا لا؟ خلينا نستنى شوي. ها؟ لا لا ما عليك. I remember it. لا بس غريبة. هم الأذرز حتى الأذر رومز ولا بس هنا؟ شوف المين رومز هناك بس. ها؟ طيب. Where did we reach? So for the IV fluids, it's okay. We'll just. Huh? You will say this is the conclusion now. You reach to the. So for the normal, so the recommendation regarding the IV fluid, the recommendation regarding the IV fluid 1 to 1.5. Regarding the types is normal saline. That's the main recommendation for the type of IV fluid. The nutrition is very important. Before we used to keep them MBO, okay, till they get better. Once they start to tolerate orally, you start immediately. Giving oral nutrition early as possible is improve the mortality and the complication later on will be much less. And also there is no difference between naso or enteral, nasogastric or nasojejunal. Before they were used to say it is nasojejunal to give the pancreatic rest. This doesn't make any difference. Actually is enteral, even maybe it's more recommended because it's easy for the patient. Regarding types of diets, it's usually start slowly, but you can advance it very quick. Before we used to say every day fluid, then solid, then no, you can over 6 hours if the patient try. Okay. نعيد من أول ها؟ Okay, so we have to monitor. That's just to remember the renal is one of the problems. If there is acute kidney injury, the associated with tenfold increase of the mortality in case of or severe acute pancreatitis. Cardiac, respiratory, and renal this is the main organ you have to follow, especially during the first 48 hours. Vital sign, at least 4 hourly, you need to do it, especially during the aggressive hydration. You have to monitor the kidney function electrolyte at least every 12 hours. And you have to also keep your eye on the urine output always. For the pain management, peripheral analgesia most of the time is not enough. So most of us, we use morphine. Morphine is safe. They were talking before about morphine will affect the sphincter of OD, but there is no evidence about that. So that's theoretically, but no evidence. The other, they use other medication, which is meperidine, but it has a lot of neurotoxicity. So morphine, even in the adult, is the one recommended. Regarding prophylactic for non-steroidal, for those patients who's going for ERCB, it is showed some effect in adults. Again, systemic procaine is again in the adults. Epidural anesthesia for those who's very sick patient in the ICU setting, it may help. For nutrition support, early nutrition support is very important. This is not support, it's treatment. Okay, so early nutrition and therapy decrease the cytokine. I'm talking about nutrition in general here. Support, it should start within 72 hours. So if you cannot start enteral, start the parenteral. So enteral nutrition is the recommended actually. And it's actually even recommended even if there is fistula or ascites or pseudocyst. Enteral nutrition decreases the bacterial translocation, which this will lead to reduce the systemic inflammatory response syndromes. We need to start as early as possible. And early as possible, we are talking about the first 48 to 72 hours maximum. If they cannot tolerate enteral, you have to start the parenteral. The enteral nutrition compared with parenteral lead to lower incidence of infection and multi-organ failure. There is no difference, as I mentioned before. And here we go back to the studies. Just see the difference here in this, while they start BO. All BO with good IV fluid is much, much less length of stay, severe attacks of acute pancreatitis, ICU admission, and even readmission. So you need to start a good IV fluid, not overhydrate, and you need to start the nutrition as early as possible. If you cannot, then you have to start the parenteral nutrition. There is no problem with protein or glucose. It's not actually stimulating the pancreatic secretion. The only things you have to monitor the glucose. May you will have hyperglycemia and you have to start insulin. There is insufficient data regarding the lipid use. So is it recommended? Is not recommended, even in adults. So this is questionable, but I don't think the lipid here is the most important. The usual contraindication for enteral nutrition, if there is ileus or complex fistula or abdominal compartment syndrome. Antibiotic, prophylactic antibiotic is not recommended. The only indication for antibiotic, if there is documented infected necrosis, or if the patient is staying still without improvements for a long time, or if there is another indication, extra pancreatic, another infection. Antibiotic, the recommended one is the one usually penetrate the necrotic tissue, like the meropenem and metronidazole. This is the common one we use. And here is the antibiotic. They use it in adults. This is adult study. And if you see, almost the same. The group who receive prophylactic antibiotic and the other groups. If you go through all of the parameters, the mortality, the length of stay, the complications, they are almost, there is no much difference. So other medication is not for pediatric. Yes, in adults, they use the protease inhibitors. It works, but it's still, even in adults, need a lot of study. Antioxidant, the studies, even in adult, is not strong enough to recommend. Probiotics actually may increase the mortality in one of the randomized big study in adults. Octreotide, it's just theoretically that to decrease the pancreatic enzymes or secretion, but there is no much evidence for use, so it's not recommended. In pediatric, is not recommended. Regarding invasive procedure, endoscopy you need it if there is suspicion of celiac disease, Crohn's disease, so if you are looking for another cause, not for the pure acute pancreatitis. Maybe acute pancreatitis because celiac or Crohn's, then you have to do endoscopy. Otherwise, not indicated. Endoscopic ultrasound, there is specific indication for diagnosis. If there is distal stone and difficult to diagnose, may you need it, or if you are thinking about autoimmune pancreatitis and you have to get biopsies, or for therapeutic purpose. For ARCB, mainly for therapeutic purpose for the stone or any biliary pathologies. Surgery, try to avoid surgery as much as you can. So you have to minimize the invasive procedure. Even if you think he needs surgery, try to use the minimum invasive procedure. If the radiologist it can help you, it's better. If the surgeon needed, then laparoscopy, so try to minimize it. They are saying is that the pancreas is like the lion. Once you touch it, a lot of problems. So try to avoid as much as you can. The only indication for early surgery, abdominal compartment syndromes, if you cannot manage it with the interventional radiologist. The other things, the necrosectomy usually is not recommended at the attacks. Usually they delay it 3 to 4 weeks later on, and that's the recommendation from the adults. So no need at the beginning. Drainage, sometimes if there is abscess and the patient is not improving, may you need it. For cholecystectomy, if the attack, biliary, due to stone, and the attacks is a mild attacks, then you have to do cholecystectomy on this admission. If it is severe attack, then you have to wait a little bit. Trauma is dependent on the trauma. If it is severe, for sure you have to explore the pancreas and see. If it is mild, try again for conservative treatment. What's the outcome? Overall is good in pediatric. The average length is 1 week in children. However, the young infants may take up to 19 days. Mortality is low, less than 5%. We are less than actually than this 5%. Some studies they are saying even less than 1%. The adult they are 5 to 10%. The higher mortality in pediatric acute pancreatitis associated with those who have systemic causes. So the etiology is mainly another systemic illness. Early onset complication in acute pancreatitis, the multi-organ dysfunction and shock, and the pancreatic fluid collection usually seen in the early onset and resolves spontaneously. There is 15 to 35% having chance for another bouts of pancreatitis later on. This is the pseudocyst and necrosis. This is the localized complication. The pseudocyst, most of the time, we will resolve spontaneously without any need for intervention. Can be infected in 10 to 15%. Necrosis at the beginning is just a collection, but later on will turn to mature, initially mature walled of necrosis. So this is the serious in pediatric about outcome. So if you see, most of them, they are okay, but there is one patient end with diabetes and with exocrine insufficiency and persistent pseudocyst. So still you need to follow them. Even if they are recovered, you need to follow them, especially if there is necrosis. And by the way, necrotizing enterocolitis, to define that is if it is more than a third of the pancreas or the length of necrosis more than 3 centimeters, that's considered necrotizing enteropancreatitis. So the conclusion, intravenous fluid therapy is ministry of treatment. The early nutrition, especially intra-nutrition, support, reduce complication, and improve survival. Still, we need a lot of studies regarding the scoring system, to develop a scoring system. I think with this group of Inspire, I think they start just in 2012. We are going to have more of data regarding acute pancreatitis. Thank you.